All right, good afternoon everybody and welcome to this Geary Institute seminar. And this seminar today we have a double act. We are going to hear from Elsa and Katia, and I'm going to introduce them separately now, and then I will let Elsa take the floor, followed by Katia. So our first presenter today is Elsa Lorthe, who is a researcher in epidemiology at the Unit of Population Epidemiology from Geneva University Hospitals in Switzerland. And Elsa's presentation is From Clinical to Population Epidemiology, Women and Children First. And Elsa is visiting us here this week as our Transnational Access visitor on the Coordinate project. So you're very welcome, Elsa. Thank you for coming to Ireland and sharing your research with us. Then our second speaker today is Katia who is Associate Professor at the Educational Sciences Centre at the University of Helsinki. And Katia is going to present on job burnout, parental burnout and study burnout. How are they associated with each other? And Katia is here today courtesy of the Geary Institute and their visiting scholar program. So thank you very much to the Geary Institute for helping Katia visit the Geary and Ireland, and you're very, very welcome. And thank you for coming here to share your research with us today. So I'm going to chair this session. My name is Jennifer Simons, and I am an adjunct professor at UCD at the School of Education, and I'm also a professor at the University College London in the Social Research Institute. So the way that we're going to do this session today is Elsa is going to talk for about 15 minutes, and then we'll take some questions on Elsa's presentation. And then Katia will talk for about 15 minutes and we'll take some questions on Katia's presentation. And if there's time at the end, we can just have a discussion on both presentations, or we could discuss other things as you like. We are at a Social Sciences and Policy Institute here, so there's many different things I'm sure we could talk about. But hopefully it will be all related to that. Thank you.
Thank you, Jenny, for this introduction. Hi to everyone. I don't think I've seen many of you, but it's really my pleasure to be here for this week.
When you choose the clicker then?
Nope.
No, technical difficulties. Oh, what's going on? Just being highlighted. Oh, it's down here. Oh, I might just go. You just click the arrows.
So you cannot choose the
No, you just can't. Yeah,
no,
it just has to be on that.
Okay.
All right.
Thank you. So I thought I would start this presentation with a little bit of my academic and professional background, because I used to be a midwife. So that's my first background, medical studies in France. And for many years, I was working both as a midwife and as a study coordinator for a randomized control trial and a cohort study in Paris. And I was really interested by this, and I wanted to learn more about what I was doing on a daily basis. So I went for a master's degree in epidemiology. And during this internship, I just fell in love with research. So I decided to embark on this PhD journey, which I completed in 2017. And then I moved to Portugal as a postdoc researcher at the Institute of Public Health of the University of Porto. And in 2020, when the pandemic began, I wanted to contribute as an epidemiologist to what was happening. So I joined a lab in Switzerland, which was very active, and I will tell you a bit more about this. So this is a word cloud from my publications on PubMed. There's a tool that you can use. It's actually pretty fun. So you can see that preterm comes as a big topic in my research, but children and women as well. And for today, I decided to give you an overview of the work I've been doing in clinical epidemiology about preterm birth, and then on population epidemiology about children and the pandemic. So we start with the first topic on preterm birth. I don't know if you're familiar with what preterm birth is, but it's basically defined as any birth between 37 weeks of gestation. There are different degrees of severity. And what you should maybe learn here is that 1 in 10 babies is born preterm worldwide, which is a lot. It's about 15 million babies a year. And actually, preterm birth is a leading cause of death and morbidity when babies are in the neonatal period, but over the life course as well. And those complications, they come from direct consequences of preterm birth, but as well from infection, for instance, because those babies are more fragile. My research has been mainly focused on a specific complication of pregnancy, which is called PPROM, standing for preterm pre-labor rupture of membranes. So it's basically when the water breaks before the beginning of labor and before 37 weeks of gestation. It's actually a pretty common complication of pregnancy because it occurs in 2 to 3% of pregnancies, and it's the leading cause of preterm birth. Contrary to what you may see or know from the movies, usually you don't give birth within 5 minutes when your water breaks. And actually, when it happens so early in pregnancy, the pregnancy can keep on for a few hours to several weeks. So my interest is really on the management of these women to try to make sure that their baby are given the best chances in life afterwards. And this pathology involves a lot of complications with mortality and morbidity, which are related to the complications, mainly infectious complications. So I told you that my interest was on the antenatal management of these women. And one question that we have is what kind of medication should we give to these women to make sure that they don't get infected or that the baby will get better. One of the treatments that we can administer is called tocolysis. It's a medication that aims to stop uterine contractions to try to prolong pregnancy as much as possible. And my question was, should we administer this treatment to women with PPROM, and will that improve neonatal outcomes? So I started by studying this question in a French cohort of preterm babies born in 2011. So this was an observational study. So when you want to study the effect of a treatment in an observational study, you have to take care of indication bias, for instance, because those who receive the treatment probably have different characteristics compared to those who didn't. So using appropriate statistical techniques, namely a propensity score analysis, I could show that women who received tocolysis, there was no difference regarding the survival without severe morbidity in their babies, in the prolongation of gestation, or in an infectious complication that is called chorioamnitis. Then during my postdoc, I tried to study the same question based on European data from the EPIS cohort of very preterm babies with a different approach, which is complementary because I studied unit policies. So we know that there are some maternity units that always administer this treatment, others that never give this treatment. For instance, I think that in Ireland, you're more on the never side. And other ones that sometimes give the treatment, sometimes not. And the conclusions of this paper was that the unit policies were not associated with an improvement in the baby's health. Based on those results, we decided to implement a randomized controlled trial in France that was funded by the French Ministry of Health. So this is called the TOCOPRIM trial, and basically we chose a tocolytic treatment, which is called nifedipine, and we have a placebo, and we are including women, randomizing them, and then we see the evolution. Unfortunately, I don't have any results because this trial is still ongoing. I think we have 2 more years to go. But another question that we are interested in is getting to know, are there some long-term consequences of this treatment? Because when we give a medication to a pregnant woman, we always have this question in mind, will there be any specific complication in the baby? So I use the EpiPage2 data to study neurodevelopmental outcomes at 5 years, and it's a paper that was published recently, where I compared these 2 groups, as usual, of women with and without tocolysis during pregnancy, and we could show that there was no difference in the outcomes of this baby, which is, on the one hand, reassuring. We are not doing harm to those babies, but at the same time, we are not improving their health. So it questions our practices and why are we giving a treatment if there's no improvement in. And we will take advantage of the randomized controlled trial to, because we have this group of women and their babies. So we will follow these babies when they are 6 years of age. We recently received funding for that. So this project is called the TOCO Kids cohort. And there will be 3 components in this follow-up. First will be a parental questionnaire, then some medical data coming from the health book, and an innovative cognitive assessment by a neuropsychologist, which will be performed online. So that was a very quick overview to say that we had a very clinical question as a midwife in the hospital: should we give this treatment or not to women? And with all these different projects, we really hope to improve clinical practice and management of patients with this condition, hoping to improve health outcomes as well. Let's move now to the second part of this presentation. So I told you that I joined recently, 3 years ago, a unit in Switzerland that was very active during the pandemic. So basically, we run 4 population-based seroprevalence studies to study the frequency of having anti-SARS-CoV-2 antibodies in the population. And we had one as well on the sample of mobilized workers during the first wave of the pandemic. We were interested in having follow-up data on these participants. So we launched a digital cohort, which is called Specchio. It means mirror in Italian. And so we had a very specific focus on COVID-19 pandemic, and then we are having much more topics of interest. And when I arrived, I took the leadership of studies on children with a circle school study, which aimed to determine the transmission of SARS-CoV-2 infections in primary. And then with the circle of kids cohort study and biobank, which is a cohort that we implemented, and we started a recruitment in 2011. So we have about 2,000 participants now, who are children aged 6 months to 17 years of age at baseline, which is quite unique, having this whole age range. And our objective is to determine the direct and indirect impacts of the pandemic on their health and development. Within this project, my research is on socially and clinically vulnerable children. And I started reading the literature on pandemic-related outcomes among children, and I realized that most studies that were available, they only assessed the independent impact of unidimensional dimension of their children's lives. For instance, I'm a migrant child. Is my well-being worse or better than native-born children? But we know that children are not a homogeneous group because they have different social, economic, and demographic characteristics which shape their daily experiences and outcomes. So my research question was to try to understand how demographic characteristics intersect with socioeconomic dimensions to shape the social patterning of quality of life and mental health in children during the pandemic. And I used this concept that is called intersectionality, so you may have heard about it before. But I just wanted to give you this quote of Kimberly Crenshaw, who is the person who actually came with this word. And she says, intersectionality is basically a lens for seeing the way in which various forms of inequality often operate together and exacerbate each other. We tend to talk about race inequality as separate from inequality based on gender, class, sexuality, or immigrant status. But what's often missing is how some people are subject to all of these, and the experience is not just the sum of their parts. So basically, we are talking about power and privilege, and we are all constituted of many different dimensions, for instance, our education, our skin color, or our gender. And the closer we are to the center of this wheel, the closer we are to power. But depending on our characteristics, we can be quite marginalized as well. And my interest was trying to understand how these different dimensions intersect. So I use a statistical technique, which is called multi-level analysis of individual heterogeneity and discriminatory accuracy. So it's very complicated, but basically the idea is that I took the participants of the Circle of Kids cohort study, and then I studied 5 different characteristics, which were age, sex, immigrant background, parental education, and financial situation. And I created strata, which were defined by the unique combinations of these 5 dimensions. And then I run some multi-level analysis by nesting all the children within the strata that were considered as level 2. So in this cohort, about 11% of children had a poor quality of life and 5% of poor mental health. And I won't go into much detail, but those are the results of these models with 3 different outcomes here. And what we learn is that we first obtain general intersectionality measures. And you can see here, maybe you cannot see that well, but for instance here, the financial situation, we can see that having a poor financial situation is associated with an increased likelihood or poor health-related quality of life or parents reporting mental health. So it was interesting to see the patterning of outcomes depending on those dimensions. And another great thing associated with this technique is that we can obtain stratum-specific predicted probabilities of poor outcomes. So we have all the strata that were defined here. And you can see that for health-related quality of life, we have quite some variations by a factor of 10 between the different strata. But when you look at mental health difficulties, there's not much variation. So this is interesting because it can help us better targeting the public when we are to implement some interventions. And the conclusion of this analysis was that if we are to improve quality of life, we should specifically target adolescents and families with financial difficulties, while if we are to improve mental health, we should actually target all children and adolescents. And so I'm here because I would like to replicate this kind of analysis using the Growing Up in Ireland data to try to understand if there are some intersectional inequalities in children's mental health in Ireland. And as we have longitudinal data, I would like to know when they begin and how they evolve over time. And I think that's it. Thank you very much for having me here.